Good afternoon, everyone. We are going to start the journal club. Today, the journal club will be conducted from National Hospital, Sri Lanka. The presentation will be done by Dr. SIddiqa Ozaal. The topic is on glycated albumin for the diagnosis of diabetes in US adults. The discussion will be started. Over to you, SIddiqa.
Thank you, madam. Today, I'm going to discuss and critically appreciate of a journal article on the topic of glycated albumin for the diagnosis of diabetes in US adults. This article is published in Clinical Chemistry, which is previously known as Clinical Chemist, and the first journal was published in 1955 as a peer-reviewed journal. Apart from clinical chemistry, they also include other specialties like anatomic pathology, transfusion medicine, clinical microbiology, genomics, hematology, and toxicology. It is well recognized, abstract, and indexed in PubMed and Medline-like sites. The impact score of this journal is 9.3 according to 2023 Clarivate Journal Citation Report. The publishers are Association for Diagnostic and Laboratory Medicine in partnership with Oxford University Press. Before getting to the article, I just want to say a few words about glycated albumin. Glycation is a non-enzymatic spontaneous reaction where a reducing sugar is added to a free amino group. Here, the degree of glycation depends on the duration of hyperglycemia. In this picture, you can see the duration taken for glycation for albumin is almost half compared to HbA1c. This is faster as because it's an extracellular protein. When we see the ups and downs in measuring glycated albumin in the diagnosis of diabetes, it doesn't require a fasting sample, and it reflects intermediate duration of hyperglycemia, as the half-life of albumin is 3 weeks and HbA1c is 120 days. Compared to HbA1c, it is not affected by the presence of hemolytic process or any abnormal hemoglobins. And also, it's not affected by other causes of anemia, especially in CKD patients, where diabetes is more common, and pregnancy, postprandial hyperglycemia. Compared to fructosamine, it is not influenced by plasma protein, bilirubin, uric acid, and low molecular weight substance. Theoretically, glycated albumin is not only altered by the serum albumin levels, but in practically, when we see in altered thyroid function test, liver cirrhosis, nephrotic syndrome with massive proteinuria, the measurement of glycated albumin can be misleading. Apart from these conditions, age, obesity, other inflammatory conditions, smoking, and high TG levels also interfere with glycated albumin measurement. The main limitation is there is a little evidence regarding the interpretation of glycated albumin in different ethnic groups. Getting to the article, in this article, the study aim was clearly mentioned as glycated albumin for the diagnosis of diabetes, and the study population also mentioned as US adult. But the study design, whether it's cross-sectional cohort, was not mentioned in the title. Looking into the abstract, it is very informative, and the background, methods, results, and conclusions were subdivided and explained. The study design, study population, and study durations were mentioned in the methodology. Balanced summary of what was done and what was found was illustrated in the results and conclusion part. But unfortunately, keywords were not mentioned. So I suggest the keywords like glycated albumin, diabetes diagnosis, HbA1c, and fasting blood sugar for this article, which helps when we search this in these topics. It's easy to find this article. In the introduction part, they have explained the scientific background as the fasting glucose and glycated hemoglobin are the standard measures to use screening and diagnosis for diabetes, but it has their own limitation. Like when we get the fasting blood sugar, we need overnight fasting and it has high within person variability. When we get the HbA1c, it cannot be used in hemoglobinopathies. So glycated hemoglobin can be used as an alternative in those conditions, and compared to the lifespan, it reflects the intermediate hyperglycemia. They also mentioned about the rationale for doing this study, like though it is an alternative and complementary test for diagnosing diabetes, the clinical utility in general population is limited because there is no diagnostic cutoff. They have mentioned about their objectives, primary and secondary object in the introduction, and the citations were followed by correct reference in the introduction. When we get into the materials and methodology of this article, the study design was mentioned as cross-sectional study with a population of 4,785, and they have elaborated how they have taken the study population. Sampling design was mentioned as complex stratified multi-stage probability cluster sampling. And all three parameters, they are HbA1c, FBG, and glycated albumin, the sampling, transport, storage, and analyzing pattern were described. The HbA1c was analyzed in whole blood sample using HPLC method, whereas fasting blood sugar is analyzed in the plasma using hexakinase method. The glycated albumin was measured from the stored serum using Dimension Vista 1500, and the results were tabulated using this formula which I have highlighted in this slide. Measurement duration was mentioned as 2 years and it was conducted in America. The exclusion criteria also elaborated in this article, and they have mentioned who has donated the reagents for the measurement of glycated albumin. They have defined the diagnosis for diabetic as fasting blood sugar more than 126 milligram per deciliter and HbA1c more than 6.5% as a combined or in both in a different way. The variables like age, sex, race, ethnicity, BMI, anemia, specifically iron deficiency anemia, hypertension, hypercholesterolemia, CKD, and albuminuria also demonstrated. In the statistic part, they have mentioned how did they assess the distribution of all three parameters and how did they derive the potential diabetic cutoff. They also examined the association between all three parameters using Pearson correlation and scatter plot with Lewis smooth curves. They also evaluated the performance of glycated albumin using receiver operative curve. They have calculated specificity, sensitivity, positive predictive value, and negative predictive value. And they have compared the performance of glycated albumin to other two parameters using logistic regression model. They also explored the association between body mass index and all three glycemic markers using Pearson correlation and scatter plot. For the analyzing, they have used Stata 16.0 software. They have taken the two-side p-value less than 0.05 as statistically significant. They have mentioned from where they have taken the ethical review, and they also addressed that all participants were provided written informed consent. When we critically analyze this methodology part, the key elements of the study design were mentioned, including the study population, how the sample size were arrived. They have mentioned about the inclusion and exclusion criteria. They also mentioned how the samples were collected, transported, stored, and analyzed. But they didn't mention specifically about glycated hemoglobin sampling, the timing, and the duration of fasting in fasting blood sugar. The diagnostic criteria for diabetic and other subgroups were well defined, variables also well defined, and they have used the reference also appropriately. They have explained how the quantitative variables were analyzed, but not described why they have chosen that particular variables. All statistical methods and data interpretations were described. Here, they failed to address the potential source of bias. And ethical clearance and consent details they have mentioned under the topics of statistical analysis. They failed to, they didn't analyze certain effect modifiers like duration of fasting, specific diet pattern, drugs, acute illness, physical activity, stress, other comorbids like thyroid illness, liver disease, and nephrotic syndrome. And they didn't tell whether we can apply tourniquet or not in the measurement of glycated albumin, because these parameters can affect in the albumin measurement. When we get into the results part, they have tabulated the first table to mention about the levels of glycated albumin from 2nd to 90th percentile in the adults, comparing with other two parameters. And in the first chart, scatter plot chart, they have told about the correlation in the first A chart. They have mentioned that they have proved that glycated albumin and HbA1c having a moderate correlation. In the B chart, you can see there is a nonlinear association between the glycated albumin and the fasting blood glucose level. In the C chart, there is a strong linear relationship between the fasting blood glucose and the HbA1c level. In this chart, they have mentioned with each subcategories how this glycated albumin and other parameters are varying. Age, race, ethnicity, weight, state, everything they have categorized, and they have checked how these parameters are varying in each categories. In here, they have plotted and seen how the glycated albumin having the diagnostic accuracy comparing the four definitions that they have mentioned previously. Here again, they have specifically mentioned about the sensitivity, specificity, positive and negative predictive value for each definition comparing the glycated albumin. For an example, the sensitivity is varying from 0.376 to 0.27, comparing the four definitions that they have provided earlier. So when we critically analyze the results part, the data presented in tabulated form using and the title and labeled correctly, comprehensible, numbers of outcomes even or summary measures were reported. Association between the cutoff values and each subgroups were analyzed statistically. Sensitivity, specificity, positive and negative predicts values were calculated, but the number of participants at each variables of the study was not clearly mentioned. The number of potentially eligible, examined for eligibility, confirm eligible, those were not addressed in here. And they didn't give the reason for non-participation at each stage. Confounders also not adjusted. Looking into the discussion part, they have mentioned the key point, strength and limitation. In the key point, they have told as par with the literature, fasting blood sugar and HbA1c has better diagnostic performance than glycated albumin. Glycated albumin not outperformed to HbA1c in anemia, iron deficiency, and CKD patients diagnosing diabetic. The difference in the disease severity may explain why the results differ from existing research, because they are not sure. The other results were telling that HbA1 compared to HbA1c, glycated albumin is a good marker in anemic condition, but here they couldn't see such a correlation because the severity of CKD and other anemic condition could be different in both studies. They have found the cutoff as 6.5 and 17.8 compared to a fasting blood sugar and HbA1c levels. Both glycated albumin threshold had nearly perfect specificity but low to moderate sensitivity for detecting diabetes. So the patients with mild hyperglycemia may be missed. Other key points were old age had risk factors for increased glycated albumin, HbA1c, and fasting blood sugar. There was a non-linear relationship with BMI and glycated albumin, but other two parameters had positive correlation. Glycated albumin was weakly correlated with HbA1c and fasting blood sugar in normal levels, but it had a strong correlation at diabetic level of glucose. They have suggested additional work to understand how this differential association with BMI may affect the clinical performance of glycated albumin. The strength of these studies were, this was the first study to perform national-wide sample in America. They had a large sample size, so it's easy for them to subgroup and analyze. The key measures including glycated albumin, HbA1c, and fasting blood sugar were systemically measured by trained person, and they have used standard methods. The limitation for these studies were other parameters like oral glucose test were not incorporated, and the glycated albumin measurement was measured in stored samples, so they don't know how long it was stored and they don't know the outcome in a fresh sample. And the third limitation, the data that were collected in a cross-sectional studies were not, it's a retrospective study. So they don't know, they couldn't get how the future diabetic for the patient and what are the complications they get. In critical analysis, key results were summarized with a reference to study objectives, critically discussed with finding with the literature. What are the things supported to the previous literature and where they have contradicted, and they have explained the reason also. They have mentioned the strength and limitation of the study. They have suggested few studies for future, but the source of potential bias or imprecision were not elaborated. Other informations like conclusion, supplementary materials, author's contribution, abbreviations, conflict of interest, funding, coronaria, stock ownership, and leadership and advisory role were mentioned in this article. So in summary, the internal validity, they have adequately justified the results and it has adhered to the existing knowledge. They statistically sound according to the stroke guideline which we used to write the cross-sectional study. The external validity wise, it has good high sensitivity, specificity, positive and negative value, predictive value in diagnosing diabetic. But the research was done in a different ethnic group compared to Sri Lankans, and the cost also very high. So these are my reference. I would like to thank our Madam Dr. Gaya Katulanda and to the PG trainees of National Hospital, specifically to Dr. Meena Balasurya and Dr. Janisha Liana Gunaratne, and also to the College of Chemical Pathologists Sri Lanka for giving me such an opportunity, and for the audience who have patiently listened to my lectures. Thank you. Any questions?
SIddiqa, what about the patients who had very high albumin or low albumin levels? Have they excluded in this study?
No, they didn't mention those parts specifically. Those are the drawbacks in the studies. They have just got the albumin urea level and they have done this study.
SIddiqa, thank you very much for the presentation. And regarding the patient selection, and did they evaluate the available records for the fasting blood glucose, or did they trace the patients and get back to them? Or there any such thing in the data collection?
No, madam. Actually, what happened here was they had the records in the national documentary. Give me a minute, madam. I'll put the specific slide and explain. So what happened here was, in this particular survey, they had the data of fasting blood sugar and HbA1c. And meantime, they had the preserved serum samples of the patient. From that data, they have taken the fasting blood sugar level, HbA1c, and about the patient's other details, including the comorbids. And they have just calculated the glycated albumin level and did the retrospective analysis.
Okay, thank you. So they didn't like positively check for the fasting blood glucose, so the HbA1c, only the data they got and got for the interpretation.
Yes, madam. Yes, madam.
Any other questions from anybody regarding the study or the other parameters that we discussed here? So in the absence of questions, shall we conclude the sessions? I must thank the presentation for Dr. SIddiqa and the team of the National Hospital for participating with the Journal Club. And thank you very much.
Thank you, madam.